Welcome to another exciting episode. Thank you for the 4,000 views, 5 subscribers now. So we're growing slowly and steadily. So to support us, please subscribe and most importantly, be able to share these episodes because there might be people in your network that actually need the message. My guest today is Dr. John Paul Omuojine. I think that's correct, right?
Good try. Good try.
How do you pronounce it?
Omuojine.
Omuojine. Okay. He's a psychiatrist at Kumasi University Teaching Hospital.
Konfanochi Teaching Hospital. It's based in Kumasi.
It's based in Kumasi.
Yeah.
Okay. Then you had the psychiatry unit.
Yes, I lead the psychiatry unit and also work part-time at the university, Department of Behavioral Sciences at Kwame Nkrumah University of Science and Technology.
Okay. So I know you're interested in dementia, but more interested in delirium. I can tell you the number of times I hear you say delirium a day.
Yeah. I know everybody's tired of that.
I don't think we're tired. I think it has made me pay attention to what exactly delirium is. When you say something, I'm like, oh, what is delirium? I go and search. So I think it's important because I think it's an important subject and sometimes there can be misconceptions on what the difference is between dementia and delirium. So
Absolutely.
For starters, what exactly is delirium?
So delirium is an acute, something that usually starts or happens suddenly. It's an acute neuropsychiatric disorder. So it manifests with changes in thinking, changes in, your cognitive function, and then behavior acutely. It's common in hospitalized, older adults especially, right? But then it doesn't mean that they're the only ones that get it. Anybody can have it. And usually when somebody has delirium, there's a sudden change in their mental state. So this may be somebody who was fine yesterday, but then today they're confused. They may be speaking irrelevantly. They may be unable to even pay attention to what you're saying. In some cases, they may even, be saying things that are not there. They may be very anxious or agitated, sometimes even a little drowsy. So there are different manifestations of delirium. But the key thing is that there's a usually sudden change in cognitive functioning. And this could be, from a setting of previous normal cognition or apparently normal cognition.
Yeah.
Or it could happen in people who have cognitive impairment, like people who already have one form of dementia or the other. And in fact, it's more common. Those people are more prone to it. And, I'm sure we'll get to talk about the risk factors for that.
So what causes delirium?
What causes delirium? There's no single cause.
Yeah.
Now, it's interesting. I'm sure, the listeners are a bit more familiar with dementia. So maybe that's they actually share some risk factors. It actually shares some risk factors with dementia in that being of advanced age, if you already have some sort of structural brain damage or neurodegeneration, as somebody with, Alzheimer's may have.
Yeah.
Right. So if those are called vulnerability factors. So these are things that they can't really be changed. They're there. Age, having a neurodegenerative disorder or a stroke, significant stroke, right? But then there are what we call the precipitating factors. So the things that may trigger delirium in somebody who is already frail, cognitively, to say that. In somebody who has a high burden of vulnerability factors. Maybe something as little as a urinary tract infection. And, what they often refer to as urosepsis, where an older person usually or typically comes to the hospital confused. They can't find any cause. You test the urine and you see that they have a UTI. You treat the urinary tract infection and then they seem to get better. So that's the typical route, especially in older adults, through which a person can develop delirium. Then delirium can happen in a healthy person of your age, right? Even though you do not have, high burden of vulnerability factors, the precipitant is strong enough. For example, if, I hit you upside the head with this, and if there was, a bleeding, you had such a severe systemic infection that there was an inflammation, happening in your brain as well, then you could be delirious and confused. So it's an interplay between those factors, and the more vulnerability factors you have, the higher your risk of delirium.
So because it has similar risk factors to dementia.
It does.
And do you think a lot of like doctors, general practitioners get to miss it and maybe mistake it for dementia? So maybe in simpler terms, what is the key difference in terms of what delirium is and what dementia is, and also how can a doctor avoid missing that this is delirium?
Yeah, it's very true that they're often conflated. So one way simplify it, maybe I oversimplify it when I'm teaching about it or talking about it.
The simpler the better.
Is I see the relationship between delirium and dementia like the relationship between acute kidney failure and chronic kidney failure. If you have an acute kidney insult, you may recover.
Yeah.
But then now you're at risk of a chronic kidney disease, or it may go straight into a chronic kidney, disease if, your kidney function doesn't recover, or the person may even die.
So if you don't recover from having that, from delirium, you can end up having dementia.
Yeah, it may be the trigger for dementia, right? So it's tend to be seen as, okay, just acute confusion, treats the underlying cause. People think it's usually one cause, but quite often there are multiple causes. And that's one of the important reasons why it's key to actually detect and diagnose it. But then for delirium, you have an acute drop in cognition. It may be from normal or apparently normal levels. It may be from, pre-existing cognitive impairments. But there's an acute drop, meaning that there's something, happening acutely to the brain. We previously thought that it was previously, touted as something that was just transient. So a person comes in confused, and some doctors still think, just, find the cause and then treat it. So if somebody comes in with delirium and they have maybe a stroke or UTI, you think, okay, job done, just ignore the delirium or the fact that they're confused and just treat the UTI. When there's no longer bacteria or leukocytes in the urine, let them go home without paying attention to what else is happening. But now we know that delirium is not as benign. Delirium is associated with, adverse outcomes, increased mortality in the hospital, cognitive decline in people who already have dementia. So they may worsen. So somebody who was living independently, right, after an acute illness with delirium, they may not be able to go back home to live alone. They may have to be institutionalized. As if these resources are available where you are. Somebody who was apparently cognitively, unimpaired, in 6 months, they have a 5 times higher chance of, 5 times higher odds of being diagnosed with dementia. And then there's an independent association between delirium and healthcare costs. So in the US, actually not in the US, I think globally, anywhere between $800 and $25,000 extra.
Is that
if somebody's hospitalized? No, actually, per hospitalization.
Per hospital. Oh, okay.
So there's a significant clinical, economic burden in addition to the mental health burden, because they're at higher risk of impaired mental health, depression, and all of that. So it's distinct from dementia in that it's an acute thing. It can be transient, and in many cases, if not most, people recover at least sufficiently to, go back to or towards their previous state of functioning. But it increases your risk for all these outcomes. In our part of the world, sub-Saharan Africa, there appears to be an even higher burden of delirium. In older adults, yes, but not even just in older adults. There are tertiary hospitals where people come in 40% or higher admitted at the emergency have delirium. Global older adult estimates, they say in non-medical cases, in medical hospitalizations for older adults, 60 or 65 and older, between 19 and 30-something% have delirium. But the limited studies that have been done in sub-Saharan Africa, it's between 9-53%. These are likely related to healthcare inequities. If you go to the average medical ward in Kumasi or in Lusaka, you find people who should be getting intensive care. How many ventilators, how many intensive care beds are there?
Man.
Right. So these are some of the things that contribute to, people not just developing delirium, but experiencing more delirium than they should.
Yeah, because I think at some point, let's say, as you talk about misdiagnosis, I think if, let's say, I have delirium and maybe good case scenario, I'm hospitalized. Maybe the doctor misses it, that this is...
As they most likely will.
Yeah.
Yeah.
Because I think they're going to treat the behavior than what exactly is happening in the brain.
Oh, yeah. I mean, I can't count the number of times that I've been, like, someone from my department, maybe one of the residents has been called, you have a psychiatric case. And this is just, somebody with a UTI who may or may not have dementia, but then now they have delirium and they have behavioral manifestations of that. Sometimes the due medical diligence may not have been done because they think, oh, this is a psychiatric case. These are some of the problems that we deal with.
So then, is there medication for delirium? Because I asked about the behavioral presentation, because I think if I go to the hospital, they'll manage me most likely for behavior.
Which, unfortunately, sometimes.
But is there like medication, treatment, or management for delirium?
So
as I await the expensive medical imaging and...
Yeah. Now, delirium is still one of those, frontiers
like
that
dementia?
we're struggling with. Yes, like dementia.
Okay.
We have two main poles. So you have the hyperactive delirium, where this person may be agitated, aggressive, occasionally even violent. And because they are confused, they may pose a danger to themselves or other people. I've actually seen, I think this was actually the thing that first piqued my interest in delirium. I was fourth year medical school, and there was this older man who had just had prostate surgery, and he was delirious and restrained, tied to the bed, which is another bone that I have to pick, right?
Man.
Somehow he got himself loose, and it was very uncomfortable because, after prostate surgery, catheter in there, and he yanked it out, an inflated catheter. And, let's not go into the details of what that looked like. Hyperactive delirium can be like that. The other one, which is hypoactive delirium, they're not very, active. They may be very docile, they may even smile, they pass by, but they're really quite confused, right? They may not be fully aware of what's going on. They're not well oriented. And that one is more often missed because, they're not disturbing anybody. They're not disturbing anybody. Old lady, how are you doing? Oh, good. No problem. Bye. Meanwhile, they don't even know what day it is. Those ones are, they usually have worse outcomes because they may just be there, developing a bed sore, and nobody pays attention to that. Things like that. Delirium itself, currently, there's no medication that treats delirium. There's no cure for delirium, right? Thankfully, it tends to be transient.
Okay.
But then it doesn't go without causing some significant damage or increasing their risk for negative outcomes. But the good thing is, up to 40% of cases are preventable with non-pharmacological interventions, in multi-component non-pharmacological interventions, taking care of all the risk factors. Sensory deprivation is a risk factor. So if this person uses glasses or hearing aids, they're in the hospital, give that to them. Try to keep a comfortable environment. You should maintain proper circadian rhythm. If it's daylight out, they should get lights. If it's night, they should get a quiet room. DD, it should be a familiar face, and it shouldn't be 20 nurses coming in and out. It can be distressing because this person is in a state where they're not fully in tune with the environment. They may be very distressed, and stress itself is something that predisposes and worsens delirium. So if this person is in a stressful environment, it may prolong and even worsen delirium. So sometimes just reassuring them and, continuous reorientation, which can happen if there's a relative around, or, the faces don't keep changing and there isn't a beeping monitor 24/7 or 20 beeping monitors around like you have in the emergency department. So these are some of the things that have been shown to improve delirium, lower the risk, and then shorten the duration of delirium. So the burden of delirium, mind you, and the duration actually correlates with risk of these outcomes we spoke about. So it's important that even if you can't immediately cure it, you address the underlying causes as quickly as possible. You do what you can to make sure you're not worsening it. And in delirium, less is more.
So what you're saying is there's a chance that you could reverse the impact of delirium.
You could limit
Okay.
I would say limit. There's no, in fact, that's one of the research questions that we're looking to answer. When delirium is present, who goes on to develop dementia and why? There are a lot of questions to ask about that. We know that the burden of delirium predicts cognitive impairment later, but then we know that improving or addressing delirium, preventing it and reducing the burden to the extent that is possible improves the short-term outcomes. There's still a lot of research to do on the long-term outcomes, like dementia and all of that. That's something I'm hoping to get into.
Okay, so I'm trying to
excuse me,
to think on the side of, if let's say I'm home, I'm the guy that doesn't often go to the hospital,
like a true African dad.
Die at home. Be a man. Yeah. If I'm the guy that doesn't go to the hospital, how can I be able to pick out and say, oh, there's something going on that I may not be able to understand? Is it the behavior
in yourself or in somebody else? As a care partner of someone with delirium?
Maybe in myself, but at the same time, how am I able to tell that, okay, my friend, my family is probably having this particular...
In yourself, first of all, just don't be that guy. If you're sick, get help, right? Yeah. But at the point where you develop delirium, I mean, at that point, you're acutely cognitively impaired. That responsibility probably can't be put on you. But then it's important that if you have a loved one or you're a carer for somebody with the risk for delirium, like somebody with dementia, for instance, you're aware of what delirium is. If you notice any, sudden changes, in fact, one of the diagnostic criteria for delirium is an acute change in cognition. And who best to give you that information than somebody who knows the person's baseline, right? So if you look at the diagnostic tools that we use, one of them specifically says, ask the relative or ask a nurse if this is somebody who's hospitalized, right? Someone who has been with them to see if there's been any acute changes. So it's important to know, if you know the person, you can tell that there's been a change. But then be aware that if there's a change, it's not just, oh, this person with dementia acting up with delirium, and not addressing that could mean that there's an underlying problem that's indirectly damaging their brain through delirium, right? And increasing their chances of accelerated cognitive worsening. So it's important that you do all the things you need to do to prevent delirium and ensure that they're hydrated, proper nutrition, make sure there are no bed sores, hygiene, exercise, daylight, sleep. So just general proper, medical and physiological management.
This is maybe almost similar to dementia in terms of the presentation and maybe other types of psychosis.
Yeah, it is.
Yeah. So what's the stigma around, like, especially in Ghana, what's the stigma around behavioral changes in a person that has got maybe a mental health condition, brain health, delirium, dementia, whatever that is? What is it like?
Yeah, it's not just even in the community, even in the hospital.
Yeah.
Right. One thing that I have observed, and starting from my early days in practice, is whenever there are behavioral issues, people tend to see it as a psychiatrist problem.
Yeah.
Right. So I've had too many people who clearly need medical care. The delirium, by the way, is caused by something medical, right? In the setting of decreased cognitive or brain reserve. So this person needs proper evaluation and treatment medically, whether it's antibiotics or whatever.
Yeah.
But because they came in presenting with neuropsychiatric or behavioral symptoms, everybody just says it's a psychiatrist problem. And, the blood sugar, hypoglycemia could be a cause for delirium. Blood sugar or whatever is not checked. They don't do even the routine labs you do when somebody walks in. Maybe because they're afraid that because this person exhibits behavioral changes, they may be aggressive. People always tend to assume that. And to be honest, if they don't feel equipped to manage that or protected enough, if the setup isn't adequate or conducive to manage acute behavioral disturbances, then there may be valid fears. But then that shouldn't detract us from doing our jobs. Yeah. Right. But these are some of the things that happen, and they don't get the care that they need. People who are not aware of what delirium is and how to address it. Healthcare workers, by the way, they don't, do their best for people with delirium. So they're denied care. And of course, the general stigma that goes with deviant behavior.
Yeah.
Right. whatever the cause, anything that is considered abnormal in our part of the world, you know how that goes.
Spiritual.
Exactly. So people think, this person is spiritual, this person is a witch or something like that.
Yeah, but how many do you think, like, let's say, even because I know most of these like misconceptions and the stigma that arises, we mostly talk about it in the community, but sometimes even like amongst like healthcare professionals, right? So I'm trying to think of maybe there's a nurse somewhere that sees this person misbehaving and just go like, oh, just go and get prayed for. Not that maybe praying is bad or something, but the person might actually need the care, but they're like, maybe take them to Pastor ABC, or take them to this traditional healer. He'll do something, because the nurse herself or himself doesn't actually understand what exactly is going on. So are there like maybe initiatives, let's say specific, maybe at your hospital or at your university, where maybe there are nurses that undergo maybe particular trainings on how to understand?
That's my entire pilot. Like that's my entire research question right now. It's what I'm building towards. Unfortunately, there's no existing program or initiative, right? A lot of people don't even know what delirium is. That's gradually changing. Some of us are making a bit of noise, but it has to be more organized noise.
Yeah.
And that's what we're trying to do. So there are a lot of barriers in the way of that. So we found that, and this is not just an African problem, it's global, the under-recognition of delirium. Up to 99% of cases are not diagnosed. And some people may not see the need to diagnose it, especially if, this person comes in confused, but they have a stroke. Just diagnose the stroke, ignore the confusion, or a UTI. Just say urosepsis and ignore the delirium. But the problem is, if you do not diagnose it, you're not treating it, right? And you're not monitoring it. So if you find a UTI, if you're familiar with what they call it, Hickham's dictum says, person can have as many disorders as they damn well please, right? It doesn't have to be the one thing that you are aware of that is causing their problem. And delirium is often multifactorial. So the fact that you found a UTI doesn't mean you should ignore the other basic things that you need to do, because those other things may be contributing and prolonging the delirium. So these things are issues that we need to make people more aware of, right? Because we found that these misconceptions and the lack of tools, because let's face it, if to get a comprehensive diagnosis of delirium, I may be able to do it in 5 minutes using one of the main standard tools, confusion assessment methods, right? But then we don't have 5 minutes for everybody coming into the emergency. Shorter screening tools.
Oh, and most of the screening tools are from the West.
Exactly.
They're not actually culturally appropriate.
Absolutely. Yeah. Absolutely. So if the tool has you asking somebody, what's your date of birth? It's almost a given, right?
Yeah.
But in a 75-year-old Ghanaian or Zambian who never went to school, who can't read or write, how sure are you that they know their date of birth?
I don't know. Should ask my grandmother when she was born.
Clinically, you find a lot of people, how old are you? And they're like, maybe 55, and this person looks like your great-great-grandmother. Sometimes they use this historical calendar where they line up historical events, like when the Ghana gained independence.
It was 4 years after Kwame Nkrumah died.
Exactly. I was alive, or I was a little boy when Kwame Nkrumah died. So this person can be more than a certain age. But then that question is not culturally valid, because not everybody can give you their date of birth.
Yeah.
Right. Not everybody can give you the exact age. So if you're testing, be it long-term memory or, awareness or attention, right, you have to use fair or culturally valid tests. And these are some of the things that we need to do. Find something that's culturally valid, that works, that's short enough and simple enough to be integrated into routine workflow, such that a triage nurse can maybe do initial brief screening when an older person comes in and notes, this person has delirium, and maybe they themselves are trained to diagnose it and document it, or, the physician attending to them diagnoses it and takes up from there. They can monitor their progress. And we have like a protocol, such that when we pick up delirium, we know this and this and this, and this is what we have to do to manage, how we have to monitor. And this is basically what I'm...
So out of curiosity, when you're doing your MB, CHB, in your curriculum, when you probably did maybe psychiatric disorders, were there like elements of that curriculum that came up, and they were specifically talking about delirium or dementia?
I asked this question in the last survey I did. I asked a bunch of physicians, and delirium in school wasn't taught. Dementia was touched on, but I can't say that I graduated having a good grasp of, dementia care management and the basics of it. I knew about it, right? But it's not very well taught in our schools.
Yeah.
Even in residency, it's not very well addressed. Of course, not in psychiatry. In psychiatry, we do that. In general medicine, a lot of people,
it's like
familiar with it.
Even from my end, I think the only time I actually thought about or encountered someone living with dementia was actually when I started practicing. When I didn't know what exactly was going on, I'm like, oh, what's this? Right?
Yeah.
Then when I talked to the neurologist, then like, oh, this may be this, but we need to do a thorough screening.
Yeah.
So I just think like one of the biggest gaps, especially in sub-Saharan Africa, has to do with our curriculums need to change. They need to be more brain health inclusive, because practitioners need to know what they're actually dealing with before they mystify the disease, because there are key things like spiritual facets that every other person has. But if I understand that dementia is this, I understand delirium is this, schizophrenia is this, then it's very easy for me to know how best I can help that person or refer them to see someone who can actually help them.
Yeah, true. And one of the things that lets a lot of people with cognitive, especially older people with cognitive disorders, go under the radar, fly under the radar when they come through the hospital system is cultural beliefs.
Yeah.
So if somebody's older, they may seem, you might even pick up some indications of cognitive impairment there as a practitioner, but she's old or he's old. So you also think, it's a normal part of...
It's old age.
And added to the fact that there are no proper referral and care pathways. So like, okay, fine. Even if I, pick it up and I carry this thing on my head, where am I taking them to? What am I doing with them? What am I doing for them? So just let it go. So these are things that we need to set up proper systems.
True.
That's why we're here.
So let's say once your pilot study is done, what's next? And maybe would you want to talk about what exactly you're working on right now? And after that, what next? What do you hope to do either in Ghana, Nigeria, Sub-Saharan Africa?
Question.
What's your game plan?
Good question. I should probably, bring my laptop and just write as I'm talking, as I'm writing my pilot's application. So we've done some early work, contributed to knowledge on the prevalence of dementia, of delirium in a hospital setting. And then, we have data on the low recognition and what the doctors think, are the barriers to that and facilitators of proper delirium detection and management. My pilot is looking to co-produce culturally valid, brief delirium screening tools that can be integrated into routine workflow. So that's the crust of what we're doing now. I'm hoping that after that, we can get funding to curate or adapt an intervention package that's not, rather than just, carrying something down from importing something whole from the US or the UK or wherever, which definitely won't fly in our setting. I'm hoping to develop a protocol or an intervention package, right, for delirium in sub-Saharan Africa. So we have a brief screening tool that can be routinely used. Couple that with a management protocol or guidelines or a package that can be implemented and evaluated. If we see that this helps, this improves outcomes, it's something that we can implement broadly. That's what I'm hoping to do.
I love the idea. And I think when that is done, when the brief screening tools are done, and probably there's interventions that could be curated out of the screening tool, then it would make a huge difference in sub-Saharan Africa.
Absolutely.
Because I think in your case, you're the first person from sub-Saharan Africa that I have met that loves delirium that much. So it was very interesting, because I interact with people that talk a lot about dementia, mental health, other mental health disorders, but few people that talk about delirium. And I think most of them might be missing that particular part of
Yeah,
of delirium. So I think the intervention and the screening tools will actually come in handy, and also maybe trying to do like trainings would also be a good idea.
trying to do
like educational trainings, like capacity building.
Absolutely, that's the point of it.
Obviously,
Because
when you have a lot of money,
we're hoping to get significant funding for that. But you have to crawl before you ball, as they say. Right now we're doing pilots and, trying to build up the preliminary science. But I hope it goes somewhere, because we have to, even beyond the places where we implement and research the effect of whatever intervention we come up with, there has to be a way to diffuse that, such that if we are not monitoring, other people see the value of screening for delirium and having an organized system to try to prevent and manage delirium when it happens, at the very least among older adults. And the other bits that I'm hoping to be able to do is to uncover or clarify the additional burden of dementia that is attributable to delirium. Because that's something that a lot of people do not consider. Some people think if you have dementia, or delirium is something that happens in people who already have or who are going to have dementia anyway. But then it accelerates cognitive decline. And it's not through the typical dementia pathologies like, the amyloid plaques and strokes and all of that. It accelerates cognitive decline. And studies have shown that if you can delay dementia onset by 5 years, it's a little bit of a cynical way to look at it. But if you can delay dementia onset by 5 years, you're saving about $400,000. This is US statistics. I don't know how much that will amount to in our setting, but whatever it is, it'd still be a significant amount of money. So there's value in preventing delirium. Even if you're someone who's only interested in dementia, there's value in addressing the burden of dementia by focusing on delirium. And I think that's the highlight of my career, question right now.
Yeah. Anyway, away from delirium a bit, I think this one is because of the work that we've been doing back home. Do you think a lot of psychiatrists overprescribe antipsychotic drugs?
Yes. I think if the only tool in your toolbox is a hammer, and every problem starts to look like a nail. Psychiatry in our part of the world is very biological. And I mean, I get it. There's a big push to legitimize psychiatry as a precise, scientific branch of medicine. But the truth is, you can't take away from the fact that the mind is not just a purely biological structure. I mean, we don't have all the answers, but then there's a huge contribution of the psychosocial aspect of a person's life that determines their mental health. And sometimes the person may come and say, with depression or anxiety, right? And there's a clear situational contributor. If that's the case, and this is not somebody who has maybe recurrent episodes, it's not super severe that, they may be at risk of harm to themselves or other people, then the guidelines would tell you, okay, try a psychosocial approach. If it's mild or moderate, even guided self-help, you tell them, give them an overview of some psychological approaches, give them reading. If they are able to, do that, they do that. And with exercise, and exercise, by the way, is the first prescription on my plan, because it does wonders for me personally. So, I mean, in some cases, there are some cases where non-pharmacological approaches are the best first line. But then there are problems here. Availability. Skill. Okay. A lot of psychiatrists are heavily biologically trained in our part of the world, but psychotherapeutically, not really. And then there are not so many psychologists. And therapy is expensive. A friend of mine, he's a rapper, he says, in one of his songs, he says, Hennessy is cheaper than therapy. I mean, we'll fight that fight later. So these are some of the things, right? If they're not very comfortable, or even if you know how to, when you have 50 patients lined up outside, if you work in the public healthcare setting, you don't have enough staff, you don't have enough time. And these are some of the difficulties that, come with psychiatric care in our part of the world. Coupled with some people, they won't understand, like, you're just going to talk to me for 30 minutes or 1 hour and then I'll give you money. Like, what does that do for me? Right? They don't understand the value of psychotherapy, which has been proven to actually have neuromodulating effects in the brain with functional imaging and all of that. Psychotherapy can actually change how your brain functions. And eventually, you can have structural changes as well. But, we don't really understand that. A lot of people don't understand that yet. We're often not very psychologically minded. So there's a whole lot of work that needs to go into that space.
So that's interesting. Anyway, thank you very much for coming for this episode. And I hope when we have the next chat, it's being able to talk about the screening tools and the interventions that you're working on. Yeah, so looking forward to that.
Yeah, I hope by the next time we speak,
come on,
you'll be ashamed to wear that in front of me.
You never walk alone.
Because Arsenal are the champions. All right, great talking to you,
possibly.
brother. Great to be had on the show.
Yeah. So if you enjoyed this episode, don't forget to like, comment, subscribe, and share within your community. Catch you next time. Thank you. Bye-bye.
Bye-bye.